All right. I'm Gavin Nixon. I'm an interventional physiatrist. Just started practice up in Anchorage, Alaska. We're going to be switching gears a little bit, talking about augmented reality in spine care and some updates to what's going on in that world. Some of the formatting is off. So the purpose of this talk is just to provide an overview on the available augmented reality technology and how it can be applied to spine care, and to go over use cases and future work. So the rise of complex outpatient minimally invasive spine surgeries necessitates new imaging modalities that are safe for us, safe for the patient, that are going to reduce radiation exposure for the patient and the operator, effective to allow for more precise navigation and placement of needles or hardware. And they must confer an advantage over traditional fluoroscopic approaches, and they can't really slow down workflow or be overly burdensome to user. So this technology is really going to be helping us visualize the anatomy in a totally different way, where we're not just looking at things in two dimensions and reconstructing in our mind anymore, although that will remain a skill that we'll have to use. But I think more and more we're going to have our procedures pre-planned as things go on into the future. Just a brief comment on radiation safety. We don't really get a lot of, no one really talks about this when you go through your training, but there's a certain dose amount that you get through the whole body. It's about 50 millisieverts is what's recommended for whole body over the course of a year. With protection, you usually are far below, but it's kind of important just to see like how much radiation are we typically getting. This study kind of looked at the radiation exposure when you're doing a kyphoplasty, depending on how many levels you did. This is a pretty small sample size, but it's 5.7 minutes, plus or minus 2 minutes for a single level, add 3.9s for a 2-level, and 2.9 for a 3-level kyphoplasty. So they were looking to see how much radiation are you getting with an unprotected dosimeter. Looking at the eye, the shallow exposure to the skin, and the hand exposure. And the conclusion was you'd have to do about 300 cases a year, and that would put you over the recommended radiation exposure for your hand and for your eye. So that's a lot of cases to do, but just to give you kind of an idea of how much radiation that you're getting exposed with a procedure that a lot of people are doing. So augmented reality, what is it? It's a virtual superposition of computer-generated information onto a surface viewed through a specialized headset or heads-up display. This superimposes the anatomical structures onto the live view of patient anatomy through a specialized headset or microscope. It's also called in situ holographic projection. This technology works by using pre-obtained images from a CT scan or MRI. It reconstructs them into 3 dimensions, and you superimpose them onto a patient using skin tags or different surface markers onto the body. This can be done basically to help you navigate where you're going to be in space and do planned trajectories. So this is kind of an older paper from the European Spine Journal in 2020, but you can kind of see what this might look like if you're looking through the headset and with a planned trajectory for here, which I think with this paper was a facet injection. So we'll kind of get through into where all this is heading. The history of augmented reality, the first heads-up display microscope was in 1986. They did a percutaneous vertebroplasty with a heads-up display in 2013. They did the first minimally invasive cervical foraminotomy in 2018, and then a TLIF in 2020. Now we're moving, a lot of the research is looking at pedicle screw placement for spine surgeons. So the pace of research is really picking up, specifically around spine surgery, pedicle screw placement, brain tumor navigation, and percutaneous vertebroplasty has also been looked at. The real applications overall for us are mainly around the navigation component, but also this is being deployed for a lot of physician training. I don't know if you guys have heard of Med-Ed Combine, which is an interventional pain program. They do a lot of training virtually through augmented reality as well, so you can kind of walk through the workflow of a procedure, first off looking at it with a headset on. So it's being developed. This is kind of a new way to look at the anatomy and learn anatomy as well. Specifically with the use of spine, like I mentioned, this is going to be projecting an anatomically correct hologram combined with a planned trajectory for guided navigation. This is just a clip where you can see where the trajectory is planning. You'll be looking down at the patient, and a heads-up display will be in front that shows the slices of your images, which you'll be able to pan through, and we'll be able to do some of this in lab as well. The applications for kyphoplasty, this is a study that was done at a hospital in China. It was a 3-level kyphoplasty where they essentially just did the pre-procedural planning, where they had their trajectories planned before going into the case. They used the Microsoft HoloLens, and during the case of the procedure, they were confirming with the C-arm, but this was kind of the first proof of concept of how can we do these procedures with visualizing the anatomy overlaid on the patient while we're doing the procedure. This was a case control study of the European Spine Journal in 2020. There was a total of 18 patients undergoing vertebroplasty with this ARCAS, which is Augmented Reality Computer Assisted Spine Surgery System. Really, the conclusions of this paper showed that it was a feasible system for percutaneous vertebroplasty. It provided a more precise bone entry with reduced operative time and unnecessary radiation exposure, which kind of meets the criteria of what we're looking for when bringing on a new technology. This was a study briefly that looked at sacroplasty. This was more of a proof of concept. In this study, there was really no significant difference in the radiation dose or the time, so it didn't provide too much of an advantage when they looked at this kind of smaller study. This is a group out of South Korea that has really been kind of leading the way for less of the trocar placement, more for needle placement. This is the first study done clinically for lumbar epidurals. This is probably what we'll start to see more and more of in the conventional procedure suite, where we have these visual tracking tools that these are constantly looking at basically QR codes that are going to be attached to the trocars or the needles that we're using. And then this is the reference marker that helps track where the patient is in time to the heads-up display. So these patients in this study were all scanned with these markers on the back. Then they were put on the table. The physicians then planned their trajectory on the CT scan. The CT scan was reconstructed, so you can see where exactly the trajectory would be. This picture is not my favorite, but it just goes to show that once the patient's on the table, there has to be a large QR code that is able to reference track with your headset that's always looking at this code. And every tool that you're using has some sort of tracking device that helps you know where you are in space, as well as where the skin markers are, so everything's superimposed onto the patient. This is a picture from one of the previous studies they had done on a phantom cadaver when they were doing the proof of concept that you could actually drive a needle under augmented reality and achieve correct needle placement with much less need for consistent fluoroscopy. So the results of this study was the first randomized controlled trial reporting clinical application for augmented reality navigation for an interventional procedure other than surgery. Really the takeaway here is the T1 time was the time to get your needle in your correct trajectory. T2 time was the duration until the procedure was complete. In the AR navigation group, all of the times were much faster than the control group using conventional fluoroscopy, and the number of pictures that had to be taken during the procedure was significantly lower than your traditional fluoroscopy as well. So this was an interesting one. This is an interesting one because if you can really just have the whole procedure planned before you do it, it minimizes the need to constantly be taking pictures. If you have very complicated anatomy, then you already kind of know where you're supposed to go. The major players in the space, there's a lot of companies. There's basically a new company coming on the scene. The one that we're going to see in lab today is Mediviz that just got FDA approval in April of this year. They use the Microsoft HoloLens, and they use sort of this visual tracking equipment here. Some of the others FDA approved for spine navigation is the Augmetics heads-up display here. And then there's a local company, Proprio. They are also working in this space as well. The kind of distinction between some of these is that as we integrate AI into the imaging, it's going to be able to start helping the pre-procedural planning. There'll probably be a point in time where it will just start to know what exactly we want to do before we even need to do it. And you'll be putting on a display and the trajectory will already be planned. So it's very interesting technology. Most of this is being pushed through spine surgery. I don't really see that this is happening a lot in the interventional space. This group in South Korea seems to be kind of leading the way in terms of what we can do with a needle. It's a little bit tricky because a needle can bend through skin, and you're always going to have to confirm with fluoro, but it just means, like, can we take maybe 50% less pictures, 75% less pictures, and achieve these procedures in a faster, safer way using some of this technology that's coming aboard. So it's kind of open for research for anyone. You can reach out to these companies and see what can be done. But that is all I have for you guys. Any questions?
So when I first, one of the ortho surgeons in my facility, once I started doing kyphoplasty, I did like 50 last year. And he's like, you should look into O-arm to see if there's, a navigation assisted that you can do, because over the course of your career, it's a ton of fluoro. And so meeting with my surgical services director, she was basically like, sorry, these procedures don't pay enough to justify you using the O-arm.
Yeah.
And so that's the I think the big hang up. And so I know that in some academic centers, they do actually use O-arm navigation for vertebral augmentation. But for me, that was what I went through that learning journey and discovered that. So I wonder if they can get the costs down.
Yeah.
Because I think we're talking about O-arm, right, for mapping, and then using this overlay, just like the thing for spine surgery. Those, putting in pedicle screws pays pretty good.
Sure.
So there's more margin than with my little.
I mean, kind of where I see this going is that patients will probably start to be scanned with reference trackers on them at baseline. And then, if you have a procedure suite, I don't know what the cost of this is, but it's going to require tracking, these tracking cameras over the patient. It may be one, it may be two, but this at some point is probably going to become somewhat standard of care. The cost is going to have to come down. This may be something that really is pushed more in the academic space, maybe not, I'm not sure. But if this makes our job easier and safer, then it'll probably be adopted, within the next 5 to 10 years more.
Thanks for the shout out to the Med Ed Combine. I started that. That was kind of a fun little journey we went on with Jafrida. The other use of this, besides pre-op planning, that I think is applicable, especially when COVID and other issues happen, is education can go on, right? That's why we started the Med Ed Combine, was so that when you couldn't go to society meetings, you could still have a scenario much like today, and people could watch online. And so we used our augmented teaching that way. But so it's great for if you're a residency director and you have multiple sites or something, and you want to see what you could be at your office and see what the fellows are doing and stuff like that. So I think there's a lot of educational benefits. In the pain management space, the margins are really narrow. Kyphoplasty, I mean, every time I do one, the surgery center director comes to me and says, now you do realize that we're making like $150 for you to take a really high risk. I'm like, yep, we're doing it anyway. And so the margins are low, and the procedures we do, there's only certain things I think we would do that would really add up to the benefit of the pre-op time.
Sure.
Because you're saving imaging time, but are you saving time
overall
in its entirety? I think you're adding time by having to do more pre-op. So somebody tell me if I'm wrong.
Yeah, I mean, that'll be the question will you save time during the procedure if you've done 5 minutes of trajectory planning or not? I guess people will have to figure that out for themselves. But I always found for myself, if I look at a case and I think this is going to go really easy, that's always the one that never goes the way you want it to. So you just never know until you get in there. But
That was an interesting presentation, though.
Great.
Any other questions? All right.
Yeah. Good job. We'll put that together. I've never put that together.